Paul, I have some bad news.
I'm so sorry, Matt. Tell me more.
Hackers brought down my online business, but I managed to keep the website address.
Is there more?
And you know what, Paul? That's
Oh, no.
domain thing.
Jeez. Oh, boy. All right. Matt, I noticed my robotic vacuum cleaner, it's just not cleaning as much as it used to. It doesn't seem to be getting around the house nearly as well as it has in the past. I'm a little afraid it has rheumatoid arthritis.
God, puns suck, Paul. Why are we doing this?
This show's bad. Everything's bad.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and someone who tells me he is the
How dare you?
Sorry, the primary care physician, America's primary care physician, Dr. Paul Nelson Williams. Hi, Paul.
Hi, Matt. Thanks for that kind intro. How are you?
You feeling humble tonight?
Yep, humble's the word.
Okay, well, I'm excited. We had a great show. Joint pain in older adults. We talked some OA, we took some RA, we talked about differential diagnosis for joint pain, and then how to tailor the approach to the older adult. Our guest was the great Dr. Una Makris. And Paul, before we introduce our wonderful co-host, would you please remind people, why are we here, Paul? What are we doing?
Yeah, existentially, Matt, I'm not sure. In terms of the podcast, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you alluded to, we are joined by super producer, frequent co-host, Dr. Leah Witt. Dr. Witt, how are you tonight?
I'm great. Always happy to be back talking about geriatrics topics. And this topic is one in our series in our collaboration with Penn Geriatrics and their Age Smart Geriatric Workforce Enhancement Grant, I think called a GWEP or a GWEP, led by Dr. Rachel Miller. So tonight we invited Dr. Una Makris, and we had a fantastic conversation with her. She's a professor of medicine in the Division of Rheumatic Diseases at UT Southwestern Medical Center and the Dallas VA. She's always loved older adults, and she's passionate about bridging the fields of rheumatology and geriatrics. She spends a lot of her time outside of patient care and mentoring, focused on health service research and improving outcomes that matter most for older adults with musculoskeletal pain. So she joined us today to talk about her primary area of interest, so pain, joint pain and aging, and how we can optimize our approach to improve outcomes for older adults with arthritis. So without further ado, let's get into it.
A reminder that this and most episodes will be available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Una, we've been talking for a little bit. Thank you so much for joining us. The audience has heard your formal bio, but they want to know, what's a hobby or interest you currently have outside of medicine? Like, what are you into these days?
Yeah, thanks for having me. By the way, I'm really excited to chat with everyone. So at this stage of my life and my family life, my favorite hobby is probably sitting on the sidelines, cheering on my kids. I have two girls. I have a 16-year-old competitive rower. So for her, I stand on the side of a river or a lake cheering her on. I have a 13-year-old goalkeeper. So I love watching her protect her goal.
Okay. That is, I'm glad you like doing that, because I imagine you're spending a lot of time doing that.
Absolutely. It's a complete pleasure while I have them at home to cheer them on.
Yeah. A lot of early mornings on the river, I'm sure.
Yes.
Nope, sounds like a great chance to brave the elements too. So that's good. I guess my follow-up question is, I like the failure one this time around. So maybe you can tell us about what your favorite failure is and what you learned from it.
Sure. There's just so many, right, in life. So I would say that I learn a tremendous amount from failed grant applications that I need to submit. So I really study reviewer comments. And I've learned that it's not about me. Sometimes it's about the ideas, sometimes it's about the framing or the methodology, and that communicating more clearly is usually what we need to do. So I've learned a tremendous amount from those failures.
That's a good attitude to have about it. I think I've always been too intimidated to submit grants, so I don't do that. And podcasting just seems easier. I don't know about you, Paul, but that's my feeling.
Oh, for sure. Yeah, I will say reviewers for like journal articles submitted, I will harbor overt animosity towards them and hope that I never actually meet them in real life. So you're a better person than I am.
All right. Well, we have a big script. So, Leah, let's get to our first case from Cashlack.
All right. So our case from Cashlack is Mr. Carter. He's a 76-year-old man who you're seeing in your clinic for an urgent visit with several days of acute on chronic right knee pain, stiffness, and new swelling. He was carrying several boxes upstairs while cleaning his basement the morning before his symptoms started, and now he has difficulty going up and down the stairs. The pain's relieved somewhat by rest and worse at the end of the day, and he has stiffness just for a few minutes after getting out of bed. He's lived alone in his 2-story home since his wife passed away 5 years ago, and at baseline, he's fully independent in his ADLs and IADLs, ambulates without an assistive device. He's not had any falls in the last year, but he says he has to take it slow because his right knee gives out sometimes. He's got a history of hypertension, CKD stage 3A, and AFib, complicated by remote embolic CVA with no residual deficits. So it's a pretty typical case in primary care. Una, could you tell us your general approach to joint pain in older adults?
Absolutely. This sounds like one of my classic cases as well, even as a rheumatologist. So I would say that the key is really to listen carefully to the patient's history. Is this acute or chronic? It sounds like this is subacute on chronic. Is the onset gradual or abrupt onset with symptoms that come on episodically? The episodic aspect might make me think about a crystal arthritis. Gradual onset, maybe osteoarthritis. Um, when I hear about acute onset, this can be related to trauma or sometimes overuse, like this gentleman going up and down stairs. And if you don't hear the history, ask about it, especially about falls. Acute onset can also be infection or septic arthritis. Um, so, really pay attention to the history. The other thing I pay attention to is the distribution of joint pain and associated swelling. So if it's monoarticular, and there's warmth that could be crystal, like gout or pseudo gout. Um, and when you think of distribution of joints, some patients will localize to the knees. Is this unilateral or bilateral? If it's unilateral, I always ask that they have a remote trauma that may result in secondary OA that can cause just one side to be affected. If they report hand pain, is this mostly in the wrists, the metacarpal phalangeal joints in here, the proximal interphalangeal joints, or isolated to the DIPs? And that all gives me clues. If we have MCPs and PIPs, I think of RA. If we have DIPs, the distal interphalangeal, I sometimes think of psoriatic arthritis, sometimes erosive osteoarthritis. And I just want to emphasize, as most patients will have multi-site pain that will include spine, knees, hips, hands, and it's important to try to tease out the different types of pain that occur because really how we treat the pain depends on the underlying diagnosis and also how we educate our patients about the pain. And so, in that sense, I just want to emphasize one important point that I speak to my trainees about, and that is, understanding how the patient's joint pain symptoms impact their daily function. So we tend to focus quite a bit on the pain intensity, the pain severity, usually with that question, that numerical rating scale, tell me about your pain rated 0 to 10. And that's very subjective, of course. So I like to understand how does that number impact their day-to-day activity? How does it interfere with hobbies or things that they love to do? So the key message here is that really high impact pain, that which interferes with daily life, is more likely to result in worse outcomes and disability. So focus on function and interference over pain severity and
Can
intensity.
I ask a clarifying question? When you mentioned multi-joint, were you saying that what you really, if they say they have multiple joints affected, are you trying to say, like, is this multiple different things? Like they have a rotator cuff and they have knee OA, or are you trying to figure out if it's the same process in those multiple joints? Is that what you were getting at?
So all of the above. I just think that the norm that we see in clinic is multi-site joint pain. So there could be different etiologies of the joint pain. You could have OA, you can have RA. I see a lot of patients with lupus and comorbid fibromyalgia, right? And so the norm is actually multiple sites of pain, and I think part of the fun is trying to distinguish, what's going on.
I don't think this will be too much of a detour, but you mentioned fibromyalgia. Is the thinking there that, like, if someone's had chronic pain from RA, lupus, something like that, that eventually they get like central sensitization and they have comorbid fibromyalgia? Is that the idea, or are people still fighting out what is actually going on there?
I think we're still fighting out and trying to determine what's happening. There are different pain mechanisms. Nociceptive is osteoarthritis in
Right.
RA, nociplastic is fibromyalgia. Do patients who tend to have longstanding RA also develop fibromyalgia? Sometimes, but not always. And so I don't think it's necessarily an issue of duration of another type of pain that increases the risk of fibromyalgia. It's a separate entity.
Okay.
Yeah.
So, all right, not too much of a detour, Paul. See, I'm a pro. I knew it wouldn't be
I'm
that
proud of
long.
you. That's strong work.
Yeah. Okay, so we're asking the person, is it acute? Is it chronic? Subacute? Was the onset gradual or abrupt? And then we're sort of getting a sense of the distribution of which joints are involved. You gave us some clues as to what that makes you think, but importantly, we're asking them about the impact on function. Okay, and you've given us a pretty good differential there. So, Leah, do you want to go to the next part of the case and then we can keep going?
Yeah, sure. So on exam, he's afebrile and hemodynamically stable. The right knee appears mildly swollen, but it's not warm or erythematous. He has crepitus and pain throughout the full range of active and passive flexion and extension. He has reduced muscle mass in his legs, and he uses his arms to rise from his chair. His gait is antalgic, but he appears steady on his feet. So what do you think of that physical exam? Does it change your approach or your differential? And do we need anything else to make the diagnosis? Are you thinking about labs or imaging?
Sure. I would say that osteoarthritis is still highest on my differential here, for various reasons. Age is certainly a risk factor. The fact that there is minimal stiffness, that it gets worse throughout the day. On exam, his exam is pretty consistent with osteoarthritis. I'm always looking for bony hypertrophy. I actually like to look for varus deformity and bow-leggedness, and I think of it like the mechanical forces that sit through the hips kind of wear down the medial aspect of the knees. I'm looking for swelling and feeling for warmth. Is there crepitus with range of motion? Is there joint space tenderness to palpation? That's probably the most common sign I see. And I'm always looking for quadricep atrophy. So, really, it's a clinical diagnosis based on history and exam. I don't need labs. And actually, I don't need imaging to confirm the diagnosis. Whenever I see a patient in rheumatology, typically they already have multiple sets of plain films. And I always ask myself, why? And so when I think about imaging, I ask myself, what am I looking for? And will it change my management? And I tend to only image if there's a change in clinical presentation, if I'm worried about a different diagnosis or progression, or if I'm referring to orthopedics and they require the imaging.
Can I ask from an exam standpoint, and I feel like I've asked this in a different context, if I remember like the evidence-based stuff like the bony hypertrophy and the varus deformity are like the really big sort of likelihood ratio changes. Crepitus, I feel like comes up all the time. But I feel like I just never know how excited to get about it, and if there's a difference between coarse and fine crepitus and what to do with it. Like, because I make the joke when I'm examining patients that the hearing test is that they can hear my knees pop when I stand up after checking their legs. So, and my knees feel fine. I probably have some arthritis, but I guess to the question, the crepitus in particular, I never quite know what to do with that information. So I'd love to hear how you think about it as a rheumatologist.
If it's not present, they can still have arthritis, right? If it is present, it's just kind of a neat exam finding that is likely related to their osteoarthritis, but in its absence, it doesn't mean they don't have the arthritis.
But also pertinent to the physical exam, you mentioned once or twice this atrophy of the quadricep. Can you talk about that a little bit?
Sure. I really talk about it, in the context of management, but I don't know where in this cycle this occurs. It's probably underuse, right? If someone has knee pain, they may be less physically active, which then may yield less, use of their joints, ligaments, muscles, and that can lead to atrophy. And so that's kind of a sign that they may be less physically active than we want them to be.
Okay. Thank you. Yeah, that's something I'll have to start. I feel like people come in, they want you to examine their knees, and they're wearing like tight jeans that you like can't pull up over their knees. It's always an issue. And then you have to make the decision, is it worth making them change it to the gown, or if you have a clinic that has shorts? Paul, do you deal with this too, or am I just the only lazy one that's like, I can pull the jeans up?
I'm going to say our staff are actually excellent at my particular small division of cash lock and making sure someone's gowned up if I need to look at stuff. So I'm in a good place right now. But yes,
right.
Historically, it's always the skinny jeans when someone has a knee complaint. So I feel your pain.
Yeah. Okay.
It's going to get worse with our generation. Our generation grew up on
worse.
skinny jeans,
Yeah, and they're going to have tattoos covering their whole leg. You won't be able to see the knee anyway.
Ruffians.
Okay, are we ready to talk about treatment, or is it too soon?
You know what? Can I make one more point that I forgot to mention about imaging?
Oh, yeah, please.
So this is especially important for older adults, that radiographic findings do not always correlate with what we see clinically. And so I just want to highlight that, I can see severe joint space narrowing, I can see sclerotic margins and osteophytes and really severe radiographic OA, and yet the patient is telling me that they're walking 2 to 3 miles a day. And so I just want the audience to kind of recognize that, and you'll see that time and time again in your clinics. And so don't make all decisions based on the x-ray. Listen to your patients and what they're telling you.
Yeah, great point.
Thanks. That's a great tip. So what is your approach to OA treatment? Where do you like to start?
So I typically start by emphasizing kind of behavioral and not a medication approaches. And I think that most of the clinical practice guidelines support that, whether it's American College of Physicians or the CDC for chronic pain. Because we're talking about osteoarthritis, I want to kind of reference the American College of Rheumatology clinical practice guidelines from 2019, which really highlight a lot of these non-pharm behavioral psychosocial approaches as well as pharmacologic management. So I usually start with emphasizing education. Like, we don't maybe spend enough time educating our patients about what's going on and what they can do for self-management or the importance of various non-medication modalities. So I end up spending a lot of time on weight management and nutrition potentially, especially since we know obesity is a risk factor for osteoarthritis. We also know certain mind-body movements like Tai Chi and yoga have been very useful and can be modified for older adults. My research specifically focuses on how do we enhance physical activity among older adults to improve pain. So I spend a lot of time trying to counsel patients how they can integrate movement into their routine. And it really boils down to access, safety, and comfort. And I usually kind of try to explain how physical activity and exercise are not all about fancy equipment and sports gear and looking good in the gym, but it could just be walking around the block safely,
Can I ask, is actually just, I meant to ask this a little bit earlier, but I think it ties into the educational component. I guess, how do you when you're talking about osteoarthritis in particular with patients, how do you talk to them about it? Because I think it's easy for it to sound as if you're saying, well, you're just older and this is what's going to happen. Like I think sometimes that's what's heard. So when you're talking about the disease process and you're sort of doing your general counseling, how do you explain the disease, or even do you, like, I guess, how much time do you even spend covering that ground?
Yeah. So my approach is to kind of explain that this is kind of a and repair, wear and repair of the cartilage. I think the language that we use is so important. So thanks for bringing this up. I think we tend to say, "Oh, it's bone on bone. It's wear and tear. You got nothing left there. And oh, by the way, go walk and exercise." And then they think, "Oh, I'm going to do more damage. It's just going to be worse for me." And so it's not the right. It's not a message that encourages engagement in the physical activity that we need and want them to do. And so I usually say, it's a breakdown of cartilage over time. This is a chronic condition. This is not something that's going to go away, but I can help you in various ways, kind of support the knee, all in an attempt to kind of improve your function. Everyone's talking about their pain, but I tend to reframe the conversation around function. And that's where the quad strengthening comes in. And that's where, if they have quad atrophy, it's a really nice visual to point to it and say, I would love for you to engage in physical therapy and strengthen this quad muscle right here. And you point to it and you say, this can help buffer and strengthen and kind of support the knee and help with the knee osteoarthritis.
Yeah, I love that reframing things. Yeah, and people anecdotally, it seems like people tell me, like, let's say someone has a terrible lifestyle, they're not moving, they're eating terribly. I've had multiple patients like tell me that they feel, just in general, all their joints feel a little bit better when they stop doing that. I don't know if there's evidence for that or if that's something people say to you as well, but I've had multiple patients tell me more that I think it's not just a coincidence, or maybe they just feel better about themselves and all their pain gets better. I don't know.
When
They're just sort of
are
like,
physically active?
if that, let's say their lifestyle is like they're doing all the wrong things. It's like high processed food
Yeah.
diet, lots of time on the couch and barely moving. And then all of a sudden they start doing some of these things and then they say, oh, my joints feel better. I've had multiple people tell me that that's the case.
Yeah, I don't think it's a coincidence. I think that movement is medicine. We've heard that many times before, but I do think if you don't use it, you lose it. And we really need to encourage movement and physical activity. And, this might be a little bit of a tangent, but a lot of our patients might feel like they're in a catch-22 situation where they have severe knee osteoarthritis and pain and they can't get moving and then their sleep is impaired. And so I think this is a very common cycle people get into. And so I actually draw the cycle with them in the middle and I talk about how can we tackle this and just jump into the cycle somewhere. And oftentimes it starts with a little bit of weight loss, with eating better and a little bit of physical activity, and then they get into a cycle and a feedback loop where they see they feel better with improved activity, nutrition, better sleep. Yeah.
Are you prescriptive about the type of home exercises they can do? Because what I've seen is like people will improve after PT and then they'll stop doing their exercises and kind of slide back. Do you have handouts or how do you counsel them for their home exercises?
That's a great question, and I've thought a lot about these prescriptions for physical activity and exercise. So I kind of look at PT a little differently. So they'll go to PT, they'll do the strengthening exercises, the stretches, range of motion, and then they'll get a home exercise program that I do encourage everyone to ask their patients about. Because once they're done with PT, the question is really, are you doing the home exercises? And if not, why not? They can do the home exercises that might involve bands. That's wonderful. But more than anything, I like them to choose a physical activity that they can integrate into their life. Park a little further in the parking lot and walk into that mall or the church or the Walmart. And so we talk about how to increase steps in various ways in their day-to-day life. For a lot of my patients, walking may not be the right modality. If they have access to a pool, aquatic therapy has been very useful. Cycling has been incredibly helpful for a lot of my patients. And so we kind of talk about what they have access to and what they feel safe doing.
Fantastic. Where are you at on topicals like diclofenac gel? I know in some of the guidelines the topicals are sort of recommended for knee and hand OA. Maybe it's harder to think how well they're going to work on the hips, but can you talk about that?
Absolutely. I'm a huge fan of topicals. Everyone gets topical diclofenac. So I will say I usually start with the options of menthol camphor or capsaicin, either the cold or the hot, and then we move pretty quickly on to topical diclofenac. And I love this because of the limited systemic absorption. And so if you have comorbidities like kidney disease, if you're anticoagulated, it may be safer. So usually I really push them, have you tried the topical diclofenac? Oh, I tried it once a week. Well, let's try it 4 times a day. It's kind of like your full-time job now to apply it to that area. If you are on Coumadin, if you're on warfarin, or if you have chronic kidney disease, I usually tell them to take it twice a day. We don't have a lot of literature on those folks because they tend to be excluded from randomized controlled trials. As I try to encourage my patients to be more physically active, sometimes I tell them, why don't you try applying it 30 minutes before you go out for your bike ride, for your walk, that type of thing. And then I really like hot and cold modalities. So that's kind of trial and error, what works for most folks, but most people really like ice packs.
What about like a knee brace? I think a lot of people's normal approach is to go to the pharmacy and just buy anything that they see that could be helpful. Do you recommend against? What do you think about those sorts of things?
So I usually ask the question if they feel unstable, and if they feel like their knee feels rather unstable, I might recommend a knee brace. Sometimes they're very bulky and they're hinged. Sometimes it's the neoprene brace that just provides enough support. And oftentimes, my physical therapist colleagues will recommend a specific brace given what they see.
Yeah, people love their knee braces. If they love them, they love them. So, Paul, you seem like a knee brace guy.
I'm agnostic. If they feel like it helps, then great, go with God. I think we've
No, I
prior
meant
episodes we talked
personally,
about.
Paul.
Oh yeah, sure. No, I just wear them just prophylactically, just in case my knees start hurting.
You wear them over your khakis, right?
Oh yeah, of course. The hinged
Over
ones
the
too. I want to
skinny
talk about like
jeans.
just the no sleeves. Like it's a whole thing. Una boost, the whole nine. Speaking of things that patients love, where are we with the naturopathic supplements? Like I have lots of people who are taking sort of joint health and glucosamine and chondroitin. I am not above recommending turmeric based on some journal clubs that we did earlier in prior episodes. But I guess what do you feel okay about? What do you recommend against, or sort of how do you counsel patients in general about these sort of other perhaps less evidence-based modalities, or I guess better ways like the naturopathic modalities?
So sometimes we don't have enough high quality data to guide these decisions. So my approach typically, and this is just my style, if they're asking me, let's say about glucosamine chondroitin, I say, are you taking it? Yes, I'm taking it. Is it effective? Does it help you? If the answer is no, I'll let them know that that's consistent with what I
Yeah.
know of the literature in the area. If the answer is it helps, I say that's fantastic. I'm glad it helps. Can you afford it? Right? So if
Yeah.
it's not effective, that is consistent with the literature for glucosamine chondroitin, um, and it can save them a few dollars in their wallet. Certainly, I do not typically recommend glucosamine chondroitin just based on the literature. I also don't reach for turmeric. If someone really wants to take turmeric, for example, um, that's fine. I am fully supportive if it helps. I also am not always clear what they're ingesting because a lot of this is not regulated. And so sometimes I'm concerned about the marketing aspect and do we know what we're actually ingesting?
Yeah, that's a tough landscape to navigate, and I find that the people that like to take supplements, and maybe they would stop if it's like, if you kind of point out to them, well, you're taking it, it doesn't seem to be helping you. Is it expensive? That's the only times I've really had people stop it. But if they like the results and they like taking it, they just take it.
That's exactly right. And sometimes if you can point out adverse effects, that's another reason to come
Good
off
point.
of them.
Yeah.
How about sort of related, I guess, with topicals like CBD cream or even oral THC, CBD? What do you counsel people about that?
I think it really depends. I mean, CBD oils are super common, um, and are helpful for many patients, so I don't dissuade them. I'm in Texas, and so some of the modalities we don't have access to and we don't recommend, and frankly, we don't have tremendous, robust data in all populations, and I do think about safety concerns in my older adult populations and kind of CNS and sedation, possibilities there. So I will say when it comes to oral pain meds, I still do trial acetaminophen. Some of the meta-analyses suggest it is not as effective as NSAIDs, but I think in the older adult population, it is a safer option and can be effective. And then I don't typically start patients on opioids or NSAIDs, but I inherit a lot of patients on these medications.
Yeah, so Mr. Carter has CKD stage 3A. So NSAIDs might be difficult for him because of the risk for his kidney disease. What would you start the acetaminophen dosing at? Like, what would you give a patient for treatment with that?
So I think he can have up to 2 grams a day, that's fine, and along with topicals. So it's very common that I will kind of lay out an approach and a menu of options that includes, non-pharmacologic, physical therapy, topicals, acetaminophen, and then follow up in 3 months. Sometimes they are actually coming to me for corticosteroid injections, so it just depends, where they are, um, as far as having tried the menu of options.
Yeah. Can you talk to us about injectables? Like, what's your practice there, and how do you talk to patients about that? Like the evidence, risks, benefits, that sort of thing.
Certainly. So in our clinic, we tend to inject glucocorticoids, triamcinolone, along with bupivacaine, so a combination into the knee joint. And our patients typically come back every 5, 6, 7, 8 months. And so we have a lot of conversations about once we start that cycle, have we tried, other options? And how can we kind of increase the time in between injections? Because we do have some data that, perhaps, injecting glucocorticoids into the knee joint every 3 months for 2 years may not be the safest option. But it's really dependent on the patient in front of me. Sometimes surgery is not an option, and sometimes this provides just enough relief and functional gains that we all agree this is the right approach. In our clinic, we do not inject hyaluronic acid. We've reviewed the literature, and at this time, there are quite a few meta analyses out there that show that hyaluronic acid preparations are not more effective than glucocorticoids or placebo. So we do not offer this. We have also seen, in some instances, a kind of a reactive effusion after
Yeah.
injecting the hyaluronic acid. So we don't offer it. And that becomes kind of a sticky point if they've tried it elsewhere and anecdotally it works for them. We try to identify a provider who can give that to them.
Yeah. I can't imagine how many millions of injections of that stuff has been given in the US over the past however many decades. But yeah, I've seen that acute reaction before, and it occurs within a few days of it, right? And it's like you would almost think it was a septic joint if the history wasn't such a clear time period? That's my just like vague. It's been years since I've seen a case, but is that sort of how it
That's
presents?
exactly right. So I have Friday clinics, and the story usually goes that they go to the ER by Sunday
Yeah.
with that type of reaction. It's that severe and that
Yeah.
painful.
Oh, well, at least it's hard to get through insurance, so that's good.
Exactly.
What do you think is going to be as far at your conferences? Are people talking about PRP and stem cells and these sort of things? And do you see any promise, or is there any promising injectable? Because people people that get their knees injected just seem to be like they get their knees injected, and it would be great if we had an injectable that we really knew worked like really well and had more long lasting effect.
And was disease modifying.
Yeah. Oh,
No?
yeah. That.
We don't have disease modifying anti-osteoarthritis meds just yet. I can't wait for that day. But really, in rheumatology conferences, we are not talking too much about PRP or stem cells. Um, I haven't seen consistently robust trials that use the same volume, that
Yeah.
use the same approach and protocols to feel confident with what we're doing there.
Yeah. And some of the cash-lack hospitals are now offering this low-dose radiation, which is something I just learned about. And it seems like it's popular in Europe based on observational data, but then they did some like sham trials and some randomized controlled trials with like sham treatment in the US, or not necessarily in the US, but they've done some randomized controlled trials of sham treatment, and it looks like it actually is just a lot of placebo effect. I'm not sure if that's something that you're seeing or people are coming in asking you for.
No one is asking about that yet.
Interesting. So it must be
They seem to be happy with my glucocorticoids.
it must be a Northeast region thing that people are starting to ask me about it now. So I guess maybe like Lyme disease, it will spread from the Northeast down towards Texas. All right. Okay. Well, Leah, I think we've done a lot of great discussion on osteoarthritis. Is there anything else here that you think we should go through, or do we want to make our patients sicker? As we do.
We definitely should. We should definitely come back to him in about a year. Before we move on from OA, when should we refer for knee replacement? Like, what's the threshold for that?
It's a great conversation to have. So I refer to orthopedics to discuss knee or hip replacement when conservative management, including PT, injections, topicals, and so forth, have failed. And also when the function is declining. And I think that's the key. And I don't like to wait too long because rehabilitation post-op for a replacement is so important. So we want to give our patients the best chance to recover from surgery before contractures might develop. I'm always asking about the social context. So, is there someone at home who could help them? And I will say a lot of patients are nervous about surgery, so they are happy sticking with conservative management until a certain point. And so it's just it's a fine line. You don't want to wait too long.
Okay, great. All right. Well, let's come back to Mr. Carter about a year and a half later. He did end up getting a right knee replacement after 12 months of conservative management. And then unfortunately, he had a post-op course complicated by delirium and an aspiration event. He was in the ICU briefly, but luckily he's recovered. But he's back to see you because over the last 3 months, he's gotten too sore and stiff to do anything. All of a sudden, he has pain from his shoulders down to his hands. His symptoms started suddenly one morning in his shoulders and spread to the joints of his elbows, wrists, and hands over subsequent days. He does have some improvement in pain and stiffness throughout the day, but he also has fatigue, chills, and reduced appetite. He tried the diclofenac gel that you gave him previously, and he occasionally uses that for his knee pain, but it hasn't provided relief for the new symptoms that he has. So what do you think is going on now, and how does your initial approach to joint pain shift with his new symptoms?
Absolutely. So we know he has underlying OA, but this is something else, right? This presentation sounds different. The acute onset The distribution of the joint pain, especially in an older adult, makes me think about late onset rheumatoid arthritis or polymyalgia rheumatica, even PMR. Crystal arthritis, especially if it's episodic, could be on the differential. In this case, it sounds like it's been pretty steady, although acute onset for the last 2 to 3 months. So I would say highest on my differential is late onset RA and PMR. And I think it's really important to think about shoulder involvement of pain and stiffness. PMR comes to mind. And in PMR, polymyalgia rheumatica, these patients can also present with hand joint involvement that make it really hard to distinguish between RA and PMR. Whenever PMR is on my differential, giant cell arteritis has to come right after. So I think that it's important to start asking questions about headaches, visual loss, jaw claudication, scalp tenderness. And so really late onset RA, we often miss this diagnosis. I've had a few cases this year already because we think of the bimodal distribution, but we really think this is a condition of younger adults. And so we don't recognize this late onset RA. However, up to 1/3 of rheumatoid arthritis patients have an onset of RA over the age of 60 or 65. So that would be late onset. And these patients tend to have more acute onset, more systemic features, which you described. They can have more PMR like symptoms. They can have large proximal joints. I really see a lot of the shoulder involvement. These folks can be seronegative, meaning negative rheumatoid factor or anti CCP. They tend to have high ESR and CRP. So that's where I would lean towards Laura, late onset RA.
Yeah, that was I mean, I knew older adults could have it, but I didn't realize that this late onset rheumatoid arthritis, Laura, was like a thing that had been described, and that this can be seronegative, and it has like a little bit of a different presentation. So I'm glad we're doing this show because I learned something. I've definitely seen it before. Can you give us any tips in primary care, like how maybe we can recognize, this earlier because or what about this one kind of jumps out at you that would make us think that this could be something? Because there's a lot of times where I see people and they're stiff and they have a lot of joint complaints, but I examine them and I'm not like, if the joints are not overtly red and very swollen, I'm just like, I don't see any inflammation. So can you tell us, like, what do you think people are missing before they get to you?
I think the biggest key is the acuity, the acute onset. These patients tend to be quite miserable, and usually the chronic inflammation, when it's missed for a long period of time, it'll start accumulating. They may have some weight loss, slightly higher baseline temperatures. Really, this unchecked chronic inflammation will take a toll on the patient. And really palpate the shoulders. Palpate very carefully for synovitis in the MCPs in the wrists, in the elbows. Check the inflammatory markers. Check for the rheumatoid factor and anti-CCP. But shoulder and hip girdle, I think it's really important to think immediately of PMR and potentially late onset RA.
When you're palpating the shoulders, what are you feeling for? Like, I feel like maybe I can determine synovitis in the wrist and sort of other joints, but the shoulder exam, is notoriously challenging for a lot of folks. But so when you're just sort of feeling around there, what are you feeling for that might suggest that this is more late onset RA picture as opposed to a PMR, or does it even help differentiate in that way?
So in a very severe case, you're going to feel warmth and there may be an effusion kind of anteriorly, especially, as you know, especially in primary care, shoulder is always multifactorial.
Yeah.
There's so much going on in the shoulder. But in this case, like you may actually feel an effusion. It may be warm. But your shoulder exam might look very typical of a rotator cuff as well, but feel for warmth
Gotcha. Thank you.
and take the shirt off looking for an effusion.
Yeah, put them in a gown, right? These are the patients that definitely need a gown. Okay, so we talked a little bit about assessments. Are there maneuvers? There's always all these maneuvers with names that I never remember. Do we need to remember any maneuver names? Okay, it's the worst.
I don't think maneuver names. I think that one of the things as a rheumatologist I see often is, examine the patient for the distribution of joint involvement and really document where the synovitis, synovitis is really palpating on the sides and above and below the joint, and then document that in the note because I usually see referrals with a zero musculoskeletal exam documented. And so it's just really helpful to know what the distribution is and if there's synovitis present. So we're not, looking for bony hypertrophy. We're really looking for sponginess in the most technical term, sponginess, bogginess, red hot swollen, where they're flinching as you palpate.
These aren't Paul Williams notes because he's America's primary care physician and he knows what he's doing. He's a
Nope. Everyone know clubbing cyanosis edema. That's my MSK exam. You're welcome.
Okay. Leah, do we have more of the case here?
Yeah. Okay, so we do an exam. So his vitals, his temperature is 99.8 Fahrenheit, and he's otherwise hemodynamically stable. His joints. Okay, so you as the primary care doctor did a great MSK exam. He's got bogginess over the bilateral MCP and wrist joints with tenderness to palpation, pain on passive and active range of motion. He's got most severe pain when he's trying to make a tight fist. His elbow and shoulders are warm and tender to palpation with pain, limited range of motion, but no micro motion tenderness or significant effusion appreciated. He has marked crepitus of his right knee with full active and passive range of motion, very mild joint line tenderness, bony enlargement, and no effusion, no tenderness of hips, pelvic girdle, or SI joints. He has no rashes. He's got some cervical and inguinal lymph nodes. So what are you thinking with the physical exam, and how does that guide your workup? Do we get labs this time? We definitely get labs this time, right?
We definitely get labs this time. So I think the key here is having this clinical suspicion for late onset RA and to refer early to rheumatology so we can solidify the diagnosis and start appropriate treatment. The labs that are helpful to order, we can order them, but it's always helpful to have them if you order them. In primary care would be a rheumatoid factor, anti-citrullonated protein. I have to add, we really don't need an ANA. Unless there's an underlying suspicion for lupus or another autoimmune disease. But, there are some panels, and I think it's the culture of the institution. Sometimes they just have I think a rheumatoid panel that includes ANA, RF, CCP, ESR, CRP, just order it all. But I think we want to discriminate here and just say this looks like an inflammatory arthritis like RA. Let's get a CCP and RF. Anti-CCP is very specific, however, can be positive in smokers, so keep that in mind. If you're worried about gout, get the uric acid. All of our patients have an ESR and or a CRP. And then the other labs I'm looking for really help guide my management and next steps. Those are chemistries. I'm looking for renal function, AST, ALT. Later on, when I'm thinking about biologics, I'm thinking about hepatitis B and C, serologies, a quantiferon, and so forth. And then if a primary care doctor really wants to be comprehensive, you can get X-rays of the affected joints, always get bilateral films, but we will tend in rheumatology to get baseline plain films of hands and feet, mostly to look for progression over time for erosive disease.
Okay, great. So let me finish the rest of the case. Then we have a lot of questions to ask you once you know all the data. So his labs, he's got mild normocytic anemia, borderline leukocytosis, that's neutrophil predominant. His creatinine is at his baseline. He's got CKD stage 3. CRP and ESR are elevated. His rheumatoid factor, SSA and SSB are negative, but his anti-CCP is slightly elevated. The Hep C and B serologies are negative. Iron studies looks like anemia of chronic disease. And then you did get x-rays of the hands, wrists, elbows, and shoulders. And he's got periarticular soft tissue swelling and juxta-articular osteopenia, but no erosions or joint space narrowing and no large effusions. And chondrocalcinosis in the left shoulder, but not the right. So, okay, you already said probably needed to put the rheumatology referral in with the labs. But let's talk about your approach to RA treatment. Like, what could the primary care doctor kick off versus what needs to be left to that rheumatology referral?
So, as far as I'm concerned, you've made my job much easier. They arrive to me with all the appropriate labs, and your physical exam is incredible. So, um, when they arrive to me, I have pretty much everything I need. I think the question is, in your system, how quickly can your patient get to the rheumatologist? So I think access varies across the country. And so just keep that in mind. If you don't have access to a rheumatologist for 3 months, happens 6 months even, you could curbside your favorite rheumatologist and ask what they would put the patient on. But typically, these patients are started on prednisone at some point. But really, I have everything I need. So I think the key message here is refer as early as possible so we can initiate disease modifying therapy because prednisone is not disease modifying.
And one tip, I don't know, Paul, if you found this too, but I will typically like tell the patient, please make an appointment with a rheumatologist, and then I will, once they have a name, I will call that person and say, hey, this person's seeing you in 3 months. Can I, and then I will often get some collaboration, and like often they'll offer to get them in sooner, but also I can start something just based on like that conversation. So that tends to work. I don't know, Una,
I
if
love
people
that.
do that, do pull that move on you, but it it usually works for me.
Yeah, I love that. And that also shows kind of interdisciplinary collaboration because we do like to communicate with the primary care doctors once they see us for RA. So that's a really nice relationship that you have.
So let's talk about this a little bit. When they're going to be seeing you, how are you going to approach this case?
So this is an older adult, and that's a passion of mine, managing older patients with rheumatic disease. So I think this is the perfect opportunity to talk about the 4 M's, the 5 M's, and how we might integrate that approach into the management of late onset RA here. So I'm sure this audience is already aware. The 4 M's was proposed by the Institute of Healthcare Improvement. They include mind, mobility, medications, and what matters most. These are a set of 4 evidence based elements of high quality care in older adults. And then multi-complexity was added later to create a consolidated framework known as the Geriatric 5 M's that helps ensure older adults receive the best care possible. They're not harmed by care and they're satisfied with the care they receive. So I'm happy to walk through kind of the Geriatric 5 M's approach as it applies to this patient. We can be brief, but I also want to kind of reference um, a really nice series on aging. We were invited to publish in the Lancet Rheumatology a series on aging, and one of the reviews focuses on integrating the 5 M's in rheumatology. So that article covers all of kind of what we're going to talk about.
Yeah, that's great. And our audience will remember we did a COPD show where we talked about the 5 M's. We did a weight loss show where we talked about it, and we did a dementia show where we talked about it. So they should know those. And I think it is a great way to approach just the older adults, and especially if there's something complicated going on. So, and like this patient that we're presenting to you is an older adult. He has multi-complexity, so yeah, I think it's a good. This framework makes a lot of sense in this case.
Super. I'm happy to kind of just think through it briefly. I usually start with multi-complexity.
Hmm.
Um, multimorbidity is defined as two or more concurrent conditions, and then multi-complexity layers on the kind of complicated biopsychosocial needs. And so, really understanding our patient's rheumatoid arthritis in the context of other comorbid conditions is important. And we recognize from the literature that patients with RA tend to have more comorbidities than patients without RA, and that increases with age. So in our case, this patient has cardiac disease, chronic kidney disease, osteoarthritis, and now RA. And these all can interact with each other and impact, pain, mobility, potential mood, social functioning. And so how do you think through this? How do you break it down? And one approach is to really ask about the pain and function. The patient has different types of pain. They have RA and OA. So asking about how this impacts and interferes with daily life. We already touched on that earlier in this conversation. Are they able to do their activities of daily living? Are they able to ambulate safely? I really love the concept of life space mobility in individuals, kind of multidimensional engagement with their environment over time. So I like to understand, where do they get around in the community and how? I also ask about psychosocial comorbidities. And I think as clinicians, it's incredibly important. We all have our lane. I'm taking care of the RA today, I'm taking care of the gout. But it's so important to ask about depressive symptoms, about anxiety, about PTSD, about social isolation. Who lives with you? Who lives around you? I tend to engage caregivers and family and friends. And this is all important because it helps with safety. It helps with medication adherence. It helps with mobility and ADLs. So I think that multi-complexity is a great place to start. And then after we understand the chronic conditions, then I kind of ask, what matters most? That's the second M I like to talk about with patients. And I think about this in the sense that the clinician brings medical expertise and the patient brings expertise in themselves and what's important to them. And so, what I love most about what I do is I get to merge that and I get to, over time, get to know what matters most to them and what are their priorities and how that shifts over time and how I might modify my management approach to align with their priorities. So if the audience is interested, we have a really nice section on what matters most in that Lancet Rheumatology article. I don't have to go into great detail how to elicit what matters most. There really isn't just one way to do that. But I would say ask the patient, don't make assumptions. If possible, engage the caregivers, engage the family.
I really like that framing of like, you're the expert in the disease, they're the expert in themselves. That's a really nice framing.
Yeah, and I think it's important to remember that because sometimes we come to the table like memorizing our clinical practice guidelines and forget that it has to fit into the context of, the social situation, the medical situation of the patient we have in front of us. So it's really working together on that.
What do you go for after? So you do multi-complexity, what matters most, and how do you think through the rest of the M's?
I usually think about medications because it goes along with multi-complexity. People tend to accumulate meds as they accumulate multiple chronic conditions. And so understanding polypharmacy defined as, I think, 5 or more medications. And we do know that our patients with RA tend to have more polypharmacy. So I believe the prevalence of polypharmacy among patients with RA over the age of 65 is 50%. And so I do suggest looking at Beer's criteria. Beer's criteria is very useful to highlight some potentially inappropriate medications in older adults and kind of highlights drug disease, drug interactions. And I will say that in patients with rheumatoid arthritis, most of them have been on NSAIDs, opioids, glucocorticoids, antidepressants. And so there's a lot of potential harm here. And so I think it's important to acknowledge that as we start new treatments, but I think it's also critical to be mindful not to undertreat older adults. And I think that's happening more and more. One of my colleagues, Dr. Jiha Lee at University of Michigan, is an expert on optimizing medication use in older adults. And some of her work highlights that up to 70% of patients with late onset RA have not been initiated on appropriate treatment after the first 12 months. And that's
Wow.
astounding.
Why do you think that is? Do you think it's ageism or I guess,
It could
unconscious
be,
or?
and I don't think we fully understand. And I think that a lot of my colleagues, and certainly we don't want to do harm, but I wonder if we're making assumptions about our older patients. Maybe we have a gestalt, we feel they're frail and we feel the biologics will cause more harm, but we actually know that biologics are very safe and very effective. And so I think we're trying to, uncover the reasons for this. But I think it's important to just be aware. Do we have biases when it comes to managing older adults? And are we under treating them? So the next M that I usually think about is the mind. And here I think again about depressive symptoms. I think of delirium, cognitive impairment, and dementia. And again, I just want to refer the audience to another review in the Lancet Rheumatology series focused on cognition. And here we discuss some of the modifiable risk factors as well as currently unknown risk factors with cognition. But we do know that there appears to be a higher risk of all-cause dementia in RA versus
Oh,
non-RA,
wow.
even after adjusting for age, sex, education, cardiovascular disease risk factors, and events. So I think it's important to ask ourselves, how does chronic inflammation impact the mind?
Wow. I didn't know about that association. That's really interesting. Is this the inflammaging that we've heard of? Is that what that term is?
Absolutely. I think it contributes here. I think it contributes. And I think that the more aggressive, though safely, we manage the inflammation, the better our patients do in all aspects. So, as a rheumatologist, I usually get a lot of pushback. I don't want to manage the cognition, but I think it's really important to just ask about it and to rule out mimics of dementia and then refer as appropriate.
Can I just ask, Paul, what do you think about the term inflammaging, Paul?
I mean, it's it's fine. I'm taking. There was a lecturer in medical school. I will never forget the line where I think it may have been a pathologist, but they said that life is basically a chronic progressive inflammatory process that ends in death, which I always appreciated.
Not grim at all, Paul. Thank you.
It is what it is. Sorry, did not mean to interrupt that non sequitur. It is a fine term to answer your question, Matt.
But we're trying to reverse it. And now we have many targets and we can at least attack the inflammatory part of inflammaging.
Well, let's talk about, because I know we're running towards the end of our time. Let's talk a little bit about what the treatment approach would be like. So you mentioned a lot of people are going to throw prednisone at somebody that has a rheumatoid arthritis flare. So if we were sending them to you, we might start, what is it, 15 of prednisone, or what dose might we start and then send them to you, and what might you start that's a disease modifying drug?
Exactly. Good questions. And it all depends also on their size,
Mhm.
what their BMI is. Do they have existing osteoporosis? What are their other comorbidities as far as diabetes? So those all come into play when I think about the dose of prednisone. Sometimes patients can get by with 10 milligrams. Other times they need 20 milligrams. I hope not 20 milligrams for a long period of time. When they come to me, if we confirm the diagnosis, if they have normal renal function, I would say that my first line is typically methotrexate. With this patient's renal function, I would avoid methotrexate. And it really depends on their comfort level. For example, and this is a conversation we talk about DMARDs, methotrexate, Plaquenil, sulfasalazine, leflunomide, and we talk about that approach where we often use triple therapy, or we can talk about biologics. And what boils down to typically is their comfort level with subcutaneous injections or infusions. We do have some other molecules, including JAK inhibitors. That's our only oral agent right now, but we definitely need to take a look at other comorbidities in that individual
Mhm.
patient.
Yeah, so probably in primary care, I don't know that I would feel, I mean, hydroxychloroquine, sure. I've started methotrexate on people. Leflunomide I'm not as familiar with, but those are, I wouldn't expect the primary care is going to even be able to get approved any of the biologics or JAK, the
hmm
oral, what did you say, is it JAK2 inhibitor or JAK inhibitor?
JAK
Yeah.
inhibitor, yeah, we have various JAKs.
Mhm.
send them to us. That's we love these patients and we love having these conversations, and we will be following them closely, every 3 months until we get their disease under
Yeah.
control. So,
This is the
please
so-called
refer
treat
them.
to target that they talk about in the when you're reading the literature. They keep mentioning treat to target.
That's exactly right. We like to have a kind of aggressive initiation, treat to target, and we're really focused on disease activity measures. My emphasis in older adults is not just the swollen tender joint count and the ESR-CRP, but I actually treat to function too.
Mhm.
So I think that's another take-home message, and we really want to be focusing on what matters most to the patients, and are we achieving the functional goals that they want to achieve.
Una, I want to make sure I didn't miss something because sometimes I'm not good at multitasking, but did we touch on mobility? I think I would like to hear more about that if we've not covered it already.
Absolutely. So mobility, I would say, is one of the most important of the M's. And here I think about falls or fracture risk and fall prevention. In this category, I also think about frailty. I want the audience to think about body composition factors, including obesity, sarcopenia, and osteoporosis. And I think one of the key messages is to ask about falls. And so I usually use the CDC questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? Are you worried about falling? And then really focusing on education, strength, balance training, and physical activity. And that kind of ties into earlier on in our conversation.
Great. Yeah, I love the 5M approach. I feel like you can apply it to so many chronic diseases. Are we ready to wrap up on Mr. Carter and get our takeaway points? Okay, so Mr. Carter presented to rheumatology. He got in a few months later. He was on prednisone 20 milligrams. He said that it seemed to his doctors that he was good enough on the prednisone, and they didn't mention anything more aggressive or any additional treatments beyond prednisone. So the rheumatologist adds on sub-Q weekly biologic injections with etanercept, and in 3 months he reports he's virtually symptom-free and weaned off of prednisone. And then at his 3-month follow-up visit, he's thrilled to tell you he's leaving at the end of the week for his annual fishing trip with his daughter and granddaughter. So what do you think of that case? Sounds pretty typical based on what you said.
Yeah, no, this is success. This is beautiful. So the patient has started on one of our TNF inhibitors, and the inflammation melts away. Typically, we see improvement by 3 months or so. If not, we can cycle and try other medications. But I think the key message here is not to assume that their function, their pain, their swelling is good enough just based on their age, and to really ask them. And I think that goes towards your previous question about ageism. And I think that's where, as a field, as a whole professional, like kind of society in rheumatology, primary care, and so forth, we really want to check our biases. We don't think of ageism like we do the other isms. I think it's under recognized. And I think sometimes we truly undertreat our older adults, and we just don't want to assume that their current function is good enough. We should ask them. And I would love if you could link to some of our recent ageism articles where we talk about the healthcare professional's perspective, but we also have one article that weaves in the patient voice about what ageism looks like from his perspective.
Great.
And before we get to take-home points, we should mention that Paul was this guy's PCP, so he made sure he was all vaccinated before he got his biologic agent, and he also is aggressively managing cardiac risk factors and all the other good primary care stuff. We've talked about that on prior episodes where we talked about RA as well. So, Paul, you're just the best.
Yeah, thanks, Matt. I agree.
Absolutely.
Una, can you give the audience some take-home points from what we discussed tonight that you really want them to remember?
Sure. So we first talked about osteoarthritis. So really focus on a detailed history and physical, maybe less reliance on the imaging or the x-rays. I would say that we're seeing increased numbers of older adults with rheumatic disease, especially RA. Keep that on your radar, even in older age. and consider using the geriatric 5Ms as an approach to improve age-friendly care in the context of RA. When it comes to what matters most, I think a key message is don't make assumptions. Really check out your own biases, and I think it's important to identify collaborators and interdisciplinary team members that can help us address the multi-complexity in our older adults. So I think those are the main points.
We can't thank you enough for all your time. I got some really great tips from this tonight. I know definitely some things that will change my practice. So thank you so much.
My pleasure. Thanks for inviting me.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Great, I guess. Still hungry for more? Join our Patreon to get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value practice-changing knowledge, and we want your feedback, so email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. I wanted to give a special thanks to our writer and producers for this episode, Leah Witt, MD, and Lee Young, MD, and to our whole Curbsiders team. Our technical production is done by the team at Podpace. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chumanchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And I've been Dr. Leah Witt.
And as always, our main Dr. Paul Nelson Williams. Thank you and goodbye.